I am KOLIOU. I'm a consultant medical oncologist treating breast cancer and melanoma at St. Luke's Cancer Center at Royal Surrey in Guildford. I've been involved in cancer treatment and research of the immune pathways for more than 10 years. Immunotherapy is often perceived as a recent treatment. In reality, more than 150 years ago, two German physicians, Busch and Feldstein, found a regression of a tumor within a short period of time after a skin infection. Since then, it has been a great revolution in treatment of skin cancers in general, with initially harness of the immune system and later on understanding each of its components, including all immune T cells. This has led to the current boom of the immunotherapy in skin cancers and especially melanoma, with the excellent results we see today. Currently, more work is being done on program T cells and CAR cells in order to treat a greater amount of patients. Historically, as you can see on the screen, there was more than a 50-year period between surgery, radiotherapy, and later chemotherapy. However, with the coming of immunotherapy, we can see that the last 7 years there is a shift paradigm with treatments overlapping the other. The last 7 years, the development of the immune checkpoint inhibitors and also immune synthetic lethality have changed the treatment paradigm with overlapping of these treatments. Many years of research has given them the opportunity today to use immune checkpoint inhibitors for patients with melanoma and other skin cancers in order to treat them. In addition, there are targeted drugs called BRAF inhibitors, which we use in patients with mutation of the BRAF protein in order to improve their survival. These treatments are used today in the early setting for stage 3 melanoma in order to prevent the cancers from coming back, as you can review on the slides. Adjuvant immunotherapy is now moving for patients with stage 2 disease in order to prevent cancer cells from coming back. But we still have 40% of patients who, unfortunately, after an initial response, do progress and further treatment is necessary. In metastatic melanoma, nowadays, with dual combination immunotherapy, we have achieved more than 50% responses in our patients over a 5-year period time. With single-agent immunotherapy treatments, as you can see on the slides, 40% of patients benefit from this treatment. With the BRAF inhibitors, 1 out of 3 patients do respond and have a good prognosis by the end of that 5-year period. The search for new immune checkpoint inhibitors has been going on for more than 10 years, but we still have lack of new agents in the treatment setting. As you can see on the slide, this is due to the high complexity of the immune response and the immune system itself. There are multiple targets that are still available for treatment, and extensive research is ongoing. One can easily understand by looking at the slide that with only 2 checkpoint inhibitors nowadays, we have achieved 50% response. So with further targets in the future, the possibility of even higher responses exists. Resistance to PD-L1 inhibitors unfortunately occurs in patients who initially have responded or in patients who did not respond initially to their treatment. Today, research is exploring multiple different targets in order to avoid resistance to CTLA-4, PD-1, and BRAF inhibitors. These include drugs such as interleukins, which have been used for many years in melanoma, oncolytic viruses, and lately new molecules such as LAG-3 inhibitors in order to improve the outcome of our patients. Recently, new techniques have been applied by using the patient's own cancer cells in order to harvest tumor-infiltrating lymphocytes, which then are reintroduced to the patient after harsh chemotherapy in order to improve their outcome and restimulate their immune system. These latest trials show response in patients with previous resistance in more than 1 out of 3 patients, and the duration of response is currently more than 3 years. There are other new molecules in the treatment and research setting, such as the CLEVER-1 inhibitors and the glucocorticoid steroid antibodies that are currently being tested. Last but not least, the gut microbiome has shown excellent results in previously resistant to treatment patients after fecal medical transplant. Multiple targets have been used today in clinical research and practice in order to improve patients with resistant disease. In reality, I strongly believe that the horizon is really bright for patients with skin cancers, and the best is yet to come.